University of Buenos Aires, Argentina, where she graduated with honors in the top 5% of her class. She completed her internal medicine residency and nephrology fellowship training at Maine Medical Center. In addition, she obtained a master's in public health from the Dartmouth Institute for Health Policy and Clinical Practice. She completed her transplant medical fellowship at Washington University in St. Louis. Before joining the Piedmont Transplant Institute, Dr. Rossi was the Associate Director of Transplantation at the Maine Transplant Program in Portland. Her special interests include access to kidney transplantation, patient education, shared decision-making, and living kidney donation. And I would like to introduce you to Dr. Rossi. Thank you so much for being here today.
Can you hear us?
Dr. Rossi, are you there?
So I'm going to cover what happens after transplant, and we can go to the next one. And we have quite a bit to cover. I'm hoping to make it dynamic, so we'll have different sections. We talked briefly about the epidemiology of kidney transplantation, and then the importance of the post-transplant follow-up with frequent visits and labs and the complications. So I think we can stop at any time here and ask questions. We'll go to the next one. So to give you a big idea of where kidney transplant and end-stage kidney disease in the United States, here you have a graph. The top dotted line in black is the number of patients with end-stage renal disease going up every year. This graph shows you up to 2016, more than 750,000 people with end-stage renal disease. That's a huge number. The second line in blue is the number of patients on hemodialysis. So the majority of patients with end-stage kidney disease are on hemodialysis. A much lower number, the following line in orange, is the peritoneal dialysis population, and much, much lower at the bottom if the transplant recipient. So you can see that very small percentage of the patients that have end-stage renal disease actually make it to transplantation, unfortunately. We wish that transplantation was a reality for the majority of them, but it's not. So, I'm not going to talk about what happens before transplant, but we want to make sure that today we cover why, once you get this precious gift, it's so important to take care of it, and what can you do so hopefully these kidneys last as long as it can. So we go to the next. And also important, transplant, because in this slide, it shows you the mortality when you are on dialysis versus when you're on get a kidney transplant. So there's no question about the bottom line there in orange is the transplant population. So it has a much lower mortality than the patients that are on dialysis or any type of dialysis, sorry. So there's a huge survival benefit to getting a kidney transplant. So another important point why we want to transplant as many people as we can. We'll go to the next one, and to put this into specific numbers, some of these I took them from yesterday, so they're very up to date from the UNOS site, the United Network for Organ Sharing. So in the United States, as of yesterday, there were over 107,000 in the wait list. This is for all organs. And active on the wait list, there were over 65,000. In 2020, to put it on perspective, there were 22,000 transplants. So as you can see, There's a very small percentage of those patients that are waiting that finally get their kidney. And at Piedmont, as of yesterday, we have 1,200, a little bit over 1,200 patients waiting. And last year we did about 272 kidney transplant. This year, I think that number is going to be greater because many of you may know that the kidney allocation system changed in March, and a lot of patients in Georgia are getting transplanted faster. So we are seeing our program grow pretty quickly. So hopefully that number will be bigger at the end of this year. So, okay, so that was, you know, who gets to a transplant. So here you go to you finally got to the surgery. So what happens during the surgery? So what you see in the big graph there on the right is your abdomen, basically. At the very top, you have your 2 native kidneys. And at the bottom on the left, you have your transplanted kidney. So your native kidneys stay where they are not removed. And your transplanted kidney usually goes on the right lower side of your abdomen or of your belly. And it has to be attached to an artery and a vein. So it has blood flow going in and blood flow going out. And then you have your ureter that gets the urine from the kidney to the bladder. And many times the surgeons, in order to keep that sutures in place and that incision to heal well, they will put a stent in the ureter for about 2 to 4 weeks. And that's why one of the things we do after your kidney transplant, about 4 weeks after your transplant, you go to see the urologist, you have a cystoscopy, and they can remove the stent once everything has healed nicely. We go to the next one. So some general facts. Remember, kidney transplant is a treatment for kidney disease, just like dialysis is a treatment. It's not a cure. It requires a lot of effort. So lifelong anti-rejection medications, follow-up, frequent follow-up, and compliance, but it will improve your quality of life and your life expectancy. So a lot of work, but it's worth doing. We'll go to the next one. So how long does a kidney last? So it's going to depend on the source of the kidney. First, is it a living donor kidney or is it a deceased donor kidney? So on the left side, you can see the average survival for a living donor kidney, a little bit over 12 years. And this is taking all comers. You know, some people keep their kidneys for decades, but this is when we average everybody together. A living donor kidney may last 12 to 15 years. Now, a deceased donor is going to depend on the quality of the kidney. And to kind of quantify a little bit the quality, we use this thing called the KVPI. Let's see. Okay, thank you. So the KVPI is a Kidney Donor Profile Index, and is basically a number from 0 to 100 that tell us a little bit of the quality of the kidney. Any kidney with a Kidney Donor Profile Index below 20 is basically going to a kid or a very young adult because those are the best kidneys that are going to last the longest. So we're trying to match the life of the kidney with the life of the recipient. And so those kidneys are very similar to deceased donor in terms of how long they last, you know, over 11 years. And then higher KVPI score kidneys may not last as long, as you can see there. But, you know, it really depends on many factors, like your age, the age of your donor, how good is your matching, but also how good are you at taking your medications, doing your blood work, you know, having regular visits. So if something is wrong, we can detect it early. So there is a lot that you can do to help this kidney last a long time. So we'll go to the next one. All right, so to help you do all those things, you have a big transplant team that is behind you. So you are going to interact with, or you are already interacting with transplant surgeons, with nephrologists, with nurse practitioners that are part of the team. Everybody gets assigned to a transplant nurse coordinators, and I have to say that they are probably the most important part of the team. They are fantastic. They can guide you through every process. They tend to be your first contact, and so your transplant coordinator will get to know you, and you will get to know them very well because you're going to be working together. We have assistants, social workers like Hannah, who is helping me today in so many ways. We have financial coordinators, pharmacists, dietitians. So it's a lot that you have to do on your side, but I want you to know that you have a huge team behind, and that's why we are here, to help you. And so you never are felt like you don't know what to do. We'll go to the next one. So starting with the visits. So it's a lot of visits. You know, some of you may be going, or maybe they were on hemodialysis 3 times a week. So it's probably not as time consuming as the beginning, but it can be pretty similar. And so this is an average of visits. Every program is a little bit different. But between visits because you have to see the doctor and visits because you have to do blood work, you know, the first month you're probably going to the hospital twice a week. The second month, maybe every 1 or 2 weeks. And then the third month, we start spacing the visits every 2 to 3 weeks. So a lot of commitment at the beginning. And then if everything goes well, we may see you only once a month to every 3 months, but we still want to probably do labs every other week or something like that. So remember, this is so we can detect if something is not going well, we can detect early, we can make the diagnosis, and we can treat early. So you have to plan for that. You have to think about, you know, how you're going to get to the transplant center and things like that. Next one. All right, so here you can see the importance of medication adherence, so your kidney can last as long as possible. So everything is interconnected. So if your kidney works for a long time, you're going to live longer, and you're going to be able to stay off dialysis, and you're going to have, you know, better quality of life. If we are able to have good kidney function, we're hopefully going to avoid rejection. So you're not going to need augmented immunosuppression, less infections, and things like that. So everything is connected, basically. Next one. So let's talk a little bit about the complications. So there's quite a few things to cover, and so we can pause and answer questions, you know, anytime. Maybe I'll take a pause here in case somebody has a question.
Thank you, Dr. Rossi. Does anybody have questions? If so, I would love for you to type them into the chat box.
You have a shout out, Dr. Rossi. Miss Dakota is here. Miss Dakota just got her transplant recently, so she wanted to let you know that she's here and rooting for you.
All right, excellent. Thank you. We are excited for you. All right, we'll keep going. So we'll talk about rejection first. And so we can go to the next one. So what is rejection? And you can do a few clicks. This is tricky when you're not doing it. This was supposed to be a little funny section that rejection can look in different ways. We are not going to talk about that. We're going to go to the next one, and we're going to talk about transplant kidney rejection. So remember, here in your graph at the bottom, you have your new kidney on the right side. So your body by design is actually, your immune system is designed to recognize this kidney as strange. You know, that's how you get protected from infection. So by design, your immune system will say, this kidney doesn't belong to me. You know, why is this kidney here? Let's attack it so we can protect you. And so that's the normal response. That's why without anti-rejection medications or immunosuppression, kidney transplant doesn't work. We'll go to the next one. So what are the risk factors for rejection? So many risk factors. Some depend on the donor and some depend on the recipient. And for example, how good is your match? So if you get a kidney from a sibling, you know, you have a pretty good chance that that will be a very good match. We call it a 6 out of 6 match. And so those kidneys tend to last the longest. Those kidneys tend to have less rejection, and those kidneys can get by with less immunosuppression. I suppose if you get a kidney from a complete stranger that you don't match at all in those 6 domains that we look at, then your risk is going to be greater. It's going to depend, that DGF means that you have delayed graft function, means that that kidney didn't work right away. Sometimes people need dialysis for a few days, 2 weeks after transplant. That is a risk factor for for rejection. At the very top there, you have a little clock that refers to the cold ischemia time. So if you get a deceased donor, that kidney is going to be on ice for a while, maybe for a few hours, maybe for 20 hours. So the longest the kidney stay on ice, the higher your risk of rejection. So there is a lot of risk factors. There is a lot of things that you cannot control, but you can control how you take your medication. So that is key, because that's how we stop your immune system from rejecting this kidney. So we'll go to the next one. All right, so what is anti-rejection medication? So we call it anti-rejection, we call it immunosuppression. Those are the same things. So what they do, they decrease the body's natural response to a foreign substance, which in this case is your transplanted kidney. So the anti-rejection medications, they lower or they suppress your immune system and prevent your body from rejecting the new kidney. So you should never stop taking your anti-rejection medications. It doesn't matter how good you feel. If you stop taking your medications or you miss, you may trigger a rejection. We'll go to the next one. And so why is preventing the rejection so important? Well, sometimes rejection is not reversible. That's why we want to prevent, and that's why we want to see you frequently, and we want to do blood work frequently, because it may not be reversible, but if you develop rejection, then if we detect it earlier, we may have a better chance to stop it. I want to say also that it really depends on how you take your medication. I also want to be clear that some rejection happens even if you're taking the medication the right way. So it can still happen, but less likely. So how do we do this? We can go to that one. And so we use very different medications. In general, the standard for, I would say, every program in the United States, with a few exceptions, but in general, we all tend to use 3 different kinds of medications. So the idea is that we will attack your immune system in 3 different ways. And so we can block different pathways, but also by combining the medications, we can lower the total doses that we use. And so less doses in general mean less side effect. So most programs use either tacrolimus, you may hear tacrolimus, you may hear Prograf and Varsus. They're basically all the same, different preparations. And cyclosporin is what we used to use before tacrolimus became available, and we still use it in some cases. So those are the 2 main ones that most hospitals use. Many hospitals, we are one of them, use prednisone, low doses of prednisone. And then many programs will use also what we call an antimetabolite. That's your mycophenolate or mycophenolic acid or Cellcept or Myfortic. They're all the same. And then the other one is called azathioprine or Imuran. So those are the 3 ones. We can go to the next one. So how should I take the medication? So a few things to remind you, just make it part of your daily routine. You can use alarms to remind you to take your meds. We really recommend that with slowly, some people are pretty fast at this, some people require more time, but learn your medications, know what you take, know the names, know the reasons why you're taking them. That will make a lot more sense. And if you have any problems taking them, getting them from the pharmacy, paying for them, let your transplant team know, because like I said at the beginning, there's a huge team behind you that is here to help you. So there's a lot that we can do to help you. And if you start having side effects or concerns, don't stop, just bring that up and we can help you, and we can talk about, do we need to change or no? What can we do to mitigate those side effects? But remember, we want to work with you on this one. Next. So the good, the bad, and the ugly of the immunosuppression. So good because it will prevent you from rejecting your kidney, and it will allow you to have your kidney stay healthy for a longer time and have a longer life and freedom from dialysis. But of course, they come with side effects and increased risk of cancer, infection, heart disease, and others. So we're trying to keep a balance on those things. So we'll talk about a little bit about the side effects next. I think I'm seeing a few questions in the chat. So maybe we can pause here if people have specific questions about the immunosuppression.
Sure, thank you. So we do have a couple of questions that have come up. One person asked, so this isn't really about immunosuppression at the moment. This question was, how often should you get a bone scan?
Okay, and I do have a little bit on bone disease in a few slides, so maybe we'll save that question for that
Wonderful.
time.
Thank you. Somebody asked, do you have to take anti-rejection medication forever?
Yes, great question. So we usually say you need the anti-rejection medication for the life of your kidney. So if you lose the kidney for whatever reason, at that time, your kidney doctor is going to start weaning your medications, your anti-rejection medication. You're not going to stop all at once, because if you stop all at once, you will reject the kidney. And you may say, well, I already lost the kidney, I'm back on dialysis, what does it matter? But if you stop your medications all at once, you will be rejecting the kidney probably in a way that is pretty painful, because you will develop a lot of inflammation in the kidney, and it can get swollen, it can get painful, you may pee with blood, so you will be weaned off the immunosuppression. So if your kidney is not working anymore, usually there's not a reason to continue the immunosuppression. Different is if you just lost the kidney and you are probably going to be transplanted very soon because you have a living donor, and maybe you lost your first kidney and now you're getting ready for your living donor transplant. And if we know that that's going to happen within 3 or 6 months, we may say, let's keep you on a little bit of the anti-rejection medication so you don't develop antibodies against the new kidney. And so that's what we say, so you don't become sensitized. So sensitization means that your body has recognized another people's DNA and they can develop antibodies. And so then that may prevent you from getting that second kidney, because now you're not a match anymore. So that would be a situation where we may want to say, okay, we'll leave you on a little bit of anti-rejection medication to prevent that, but that's rare. And so in general, once your kidney stops working, we'll start weaning you of the immunosuppression.
Thank you so much. That was really helpful.
All right, so we'll move to the next section. So lots of potential side effects of the medications. So, we say less serious side effects, but they can be problematic. So we do pay a lot of attention. So GI upset is probably the most common. It could be manifest in the way of heartburn or in the way of nausea, sometimes vomiting. Loose stools is pretty frequently. And of course, when people have diarrhea, that could be problematic because you can lose a lot of water that way. Mood swings in general is common with the prednisone. Tremors can be pretty common side effect of the tacrolimus or the cyclosporin, and those things tend to be related to the levels. So we can adjust. Acne, so that's a combination of all the medications together, but mostly the prednisone. The tacrolimus, the prednisone can increase your cholesterol. They can cause some weight gain. So there's a lot that can happen that we do pay attention. And of course, we worry a lot about skin cancer. I'm going to be talking a little bit about bone disease and then diabetes as well. So we'll keep going. This is just to give you an idea of the most common medications that we use and what they can cause. So tacrolimus, for example, the second column there that we use all the time, it does increase your blood pressure, it can increase your cholesterol, it can increase your sugars, or it can cause diabetes if you're not diabetic. It can be toxic to the kidney, actually, both cyclosporin and tacrolimus. So that is why it's so important also that we see you frequently and we do labs frequently, because we want to follow the levels, and the levels need to be just right. So too high level will cause toxicity to the kidney. And if the level is too low, you can be predisposed to a rejection. So frequent levels are very common at the beginning. And then it can cause neurologic changes like the tremors I mentioned, sometimes headaches and things like that. So a lot of different medications you're going to be taking, potential for different side effects. We'll go to the next one. So infection. So remember, we are trying to prevent you from rejecting the organ, and that's why you're on the immunosuppression, but now you're not going to be able to defend yourself as good from infection. So that's one of the side effects. So the risk of infection is going to depend on what you're exposed to. You know, if you have a friend that comes and visit and they have the flu, for example, you may get exposed to that, and now you're immunosuppressed, so you cannot defend yourself, so you could potentially get pretty sick. So it's going to depend on that, and then how much immunosuppression are you getting? For how long have you been on this immunosuppression? What kind are you taking? And then do you have other predisposing factors? So if you're diabetic, maybe you have a higher risk. Do you still have a drain at your incision? That could be a place where bacteria will enter. Or do you have a Foley catheter in your bladder, another place of entry? So a lot of things to consider after the transplant. We'll go to the next one. And so this is, you know, you don't have to know all of this. It's just to give you an idea of why we follow you so closely. And at the bottom line there, you have the time after transplant. So from 0, so from the day you got your kidney transplant to 6 months, all different kind of bacterial or viral fungal infections can happen at different times. Early on, some happen later. So this is the type of things that we are monitoring when we see you, okay? So we're paying attention to all those things. And of course, we wanna hear from you also, what are you feeling? You know, do you have signs of a urinary infection? Do you have frequent urination? Or do you have a fever? Or do you have, you know, a cough? So that's why it's so important that we follow you closely. We'll go to the next one. So what do we do to prevent the infections? Well, a lot of what we do, it actually starts before transplantation, because the vaccinations are crucial to protect you. And many of the vaccinations work better before transplant. Hannah, you can do some clicks there so things start populating. So many of the vaccinations will work before transplant, and also some of them you cannot get them before transplant because they are what we call a live virus vaccine. And so once you're immunosuppressed, if you get a live virus vaccine, you have the potential of getting the infection from the vaccine. And so some vaccines you should not get them. So on the right side, so what vaccines can you get once you're vaccinated? So we recommend the influenza, the pneumovax, the Prevnar, the diphtheria, pertussis, or tetanus, or DPT that you may hear, hepatitis A and B, and the meningococcus. This is not for everybody, but if you have additional risk factors, you know, you may want to get those. You can talk to your doctor. And then there are other medications on the right, like the varicella, the measles. You can keep clicking. So those vaccinations, you should not get them after transplant, because you can get the disease. So very important that actually you get them before transplant so you can be protected. Mostly the varicella and what we call the MMR, the measles, mumps, and rubella. And then if we go to the next one, I just wanted to be a little bit more specific about the COVID vaccination. I think that's the next slide. So what do we know about COVID? Because COVID is so new. So we know that all the vaccines available in the United States, Pfizer, Moderna, and the Johnson & Johnson, are very effective at preventing death or hospitalization from COVID in an immunocompetent person, okay? So if you're not on immunosuppression and you get these vaccines, you may get COVID, but probably you're not gonna get very sick from it, okay? So they work, they are safe, as you know, they're readily available, and they are free. But after transplant, we don't have a lot of information. We're still learning. So what we know so far is that they may not work as well. And so the protection may not be as close as 100% like it is in an immunocompetent person. So we really recommend that if you haven't been transplanted yet, that you get it before transplant. That being said, even if it doesn't work as well, we still will recommend that you get it after transplant, and not probably the first 3 months, because the first 3 months you're so immunosuppressed that even if you get the vaccine, it's not going to work. So we recommend that if you got your transplant, you wait 3 months and then you get it. Okay. And because they may not work as well, we don't know, we still recommend that you wear mask and that you continue to social distance and all those things. And now we also know that the vaccines do reduce the transmission of the virus. So the more people vaccinated around you, the more you will be protected. We'll go to the next one. This is just to give you an idea, all those societies at the bottom, the American Society of Transplantation, the Transplant Society, UNOS, all these societies support vaccination for people on the waiting list, but also for transplant recipients. So the whole transplant community is in favor of the COVID vaccine. And I want to show you the next slide, and then we'll do a pause. And so the next slide is regarding a study that we're doing at Piedmont with the Moderna vaccine. We want to learn more about the Moderna vaccine in transplant recipients in a more scientific way. So I just want to say that if you are a kidney or a liver transplant recipient and you are beyond 6 months from your transplant and you have not been vaccinated yet, and you're interested in participating in a study where you will get the vaccine and they pretty much will follow you, feel free to reach us, and we can tell you more about it. So I think I will pause here. People may have questions about this, infections in general or vaccines in general.
Nothing in the chat right now, but maybe in a little bit.
Okay.
Yeah.
All right, we'll keep going. All right, so this is more about prevention of infection. So we can go through this quickly. It's just that we use a lot of antibiotics or antivirals at the beginning to prevent urinary infections, to prevent pneumonia, to prevent CMV or cytomegalovirus. We can keep going. One more. Yeah, next. Okay, and then remember, once you are over the first 6 months after transplant, you are not as immunosuppressed as you are at the beginning. So then the majority of the infections are similar to those on the general population. So you may get the flu, or you may get a urinary infection or an upper tract respiratory infection. So after the first 6 months, things tend to be more similar to the general population. And what we call the opportunistic infections, like some of the reactivation of viruses and things like that, are less common. Okay, we can go to the next one. All right, so we'll talk a little bit about the risk of malignancies or cancer. So after transplant, once you are immunosuppressed, one of the things that the immune system does also, it doesn't only prevent you from infection, but if there is any cancer cells in your body, the immune system is always checking for that. And if they see a cancer cell, they usually destroy it. And cancer happens when the immune system fails to recognize a cancer cell. So one of the side effects of immunosuppression is cancer. So if you had a cancer before your transplant, that cancer could technically come back after transplant. Cancer could come from your transplanted organ. That is extremely rare. It has been described in around maybe 1% or less, but it's a possibility because the donors get to screen so much to make sure there's nothing like that. Or it could be a new cancer, so something that you never had before and now is happening after transplant. So the immunosuppression medications do increase the risk of cancer because of the reasons I just mentioned. And the most common one is what we call a non-melanoma skin cancer. So either what we say is squamous cell skin cancer, it may be more than 200 times common than in the general population, or basal cell skin cancer. Those both cancers tend to be pretty easy to treat if they're caught early. Melanoma is more aggressive and it can usually be problematic, but it's not as good as the other two. So we'll go to the next one. So because cancer is so common, one of the things that you can do is to make sure that you are up to date with what we call age-appropriate cancer screening. So make sure that you are up to date with your mammogram, with your Pap and your colonoscopy, and the frequency of those and when you start is going to depend a little bit on if you have risk factors or not. But talk to your primary care doctor to make sure that you are up to date with those. We'll go to the next one. In terms of the risk of skin cancer, which is the most common, things that you can do to reduce your risk is avoid direct sunlight. So use long sleeves, use hats. When you are going to be in the sun, make sure that you use sunscreen protection. We recommend SPF 50 or above. Of course, avoid tanning booths. Be aware of any skin changes. So look at your skin, frequently and see if you see any new moles or a mole that is changing that looks suspicious. And then you should ask your primary care doctor or see a dermatologist once a year, and you should have a good skin check head to toes at least once a year. We'll go to the next one. So the next one is about cardiovascular complications. So this is a big one. And so for heart disease, there are a lot of risk factors. So high blood pressure can cause heart disease, smoking, the older we are, the greater the risk. Diabetes can cause heart disease, kidney failure can cause heart disease, obesity and high cholesterol can cause heart disease. So a lot of things can cause heart disease. And the medications that we give you can make many of these things worse. So the risk of heart disease is because of those risk factors, but also because of the medications that we give you. We'll go to the next one. So high blood pressure or hypertension. So that's very, very common after transplant. Almost every transplant recipient is at least on one blood pressure medication. And that's a side effect of the anti-rejection medications that we give you, but also obesity, kidney disease in general can increase the blood pressure. So it's very common. The target blood pressure after transplant is below 130/80. And so that's where we use the medications to bring you below that. And in addition to using medication, things that you can do to lower your blood pressure are weight control. And so having a healthy weight, exercising regularly, and following a low salt diet. We'll go to the next one. And so diabetes. So I told you diabetes can cause heart disease. And so diabetes can get worse. If you have diabetes before transplant, it can get worse after transplant because of the medications. And also because of the medications, you may not have diabetes pre-transplant, but you can develop after transplant. Other risk factors for developing diabetes after transplant on top of the medications that we give you are obesity, family history, polycystic disease, and hepatitis C are more common. And good diabetes control is important because it will reduce your risk of kidney failure, so it will protect your new kidney. And if the diabetes is not controlled, you can have lots of complications like eye disease or retinopathy. You can get neuropathy. You can have a higher risk of heart disease or stroke, and of course increases your risk of death. We'll go to the next one. So hematologic complications. So this is your blood work that we do because you're not going to feel probably anything about this. So we check your blood work frequently to see if you develop anemia. That is if your red cells are low. So you may hear that we say your hemoglobin is low or your hematocrit is low. So that is called anemia. And that may be because of the kidney disease itself. But again, many of the medications we use, so the anti-rejection medications to prevent rejection, or the antibiotics that we use to prevent infections, or the antivirals. Infections can cause anemia, rejection can cause anemia, and there can be a specific process that we call abnormal breakdown of the red cells. So the red cells don't live as long, and they can cause anemia. The other common one that we'll detect in your blood work is the leukopenia, or the low white blood cells. And again, similar risk factors, mostly medications and infections that can cause your white cells to be low, and that will also predispose you to more infection. So we want to monitor those things because there's things we can do. So metabolic bone disease, I know that there was a question about this. And so this actually starts before the transplant, because kidney failure, kidney disease is related to bone disease. And so the process always starts pre-transplant. And then after the transplant, it may continue, or it may be worse because of the medication side effects, the diabetes, like we talked, lack of exercise will make it worse. There may be a genetic predisposition for osteoporosis, and then smoking, and for women going through menopause and afterwards, where the estrogen level changes, that will increase your risk. And so this is important because you could have a fracture. And to prevent, we want to do weight-bearing exercises, and then we keep monitoring your blood work so we can keep the levels of calcium, phosphorus, vitamin D, and your PTH at the right range. In terms of the bone density, it is recommended that you get a bone density 1 to 3 months after transplant to get a baseline. And then after that is usually every 2 years. So I know somebody had a question about how often to get a bone scan. So that would be the recommendation.
Dr. Rossi,
yes.
I'm going to interrupt just for a second. We're hearing somebody's phone background noise. If everybody can look and make sure that you are muted. If you look at the bottom left of your screen, there's an option to press mute. Please make sure that you are muted. Thanks so much.
Thank you. So neuropsychiatric complications. So I mentioned tremor before. Depression, mania, and anxiety. So, you know, those can happen as side effects of the steroids mostly. And steroids, at Piedmont, we use a big dose at the time of transplant, but then we drop you to a low dose pretty quickly. So the risk is much lower, but it can happen. It can cause mood swings in an unpredictable way. So that may be more prominent if you have a prior history of depression or anxiety. So we will monitor you closely. Delirium is mostly for the older recipients that they're on a lot of medications. It's not that common. And then some visual changes, mostly the long term of prednisone can cause cataracts. We'll go to the next one. So I mentioned at the beginning part of the complications, some of the GI, so gastrointestinal complications. So a lot of different medications can cause the gastritis or peptic ulcer disease, or the loose stools, the diarrhea, and then hepatitis. So sometimes early on, patients have a little bit of inflammation of the liver because of all the new medications that we are using, and then we kind of adjust things and that goes away. It's extremely rare to get hepatitis B or C, but it is a possibility. And so that's something that we also monitor, and the units have new requirements, and everybody gets checked for this 1 month after transplant, basically. We'll go to the next one. Cosmetic complications. So this may not affect, you know, the life of your kidney, but they're a big deal because we want you to feel better after we transplant you. So if these things are bothering you, then we want to work with you and see what we can do to help you feel better. So cyclosporin, for example, may cause hair growth. And so, you know, it may be facial hair for a woman. So we want to do something about that. They may cause weight gain and swelling. Cyclosporin also can cause swelling and bleeding of the gums, so we have alternatives to that. Again, the GI upset could be an issue in your social life. It does frequently. Mood swings, tremors, acne, and skin stria, like we discussed before. So if you are worried about these kind of things, we want to know, we want to work with you, because most of the time we can do stuff to make them better. Next one. So I know I'm running out of time, but tobacco, many reasons why smoking is bad. It's bad for your kidney, it's bad for your heart, it's bad for your vessels, increases the risk of stroke and things like that. So we really want you to avoid all tobacco products. I forgot to include marijuana here, but marijuana or CBD oils can interfere with the tacrolimus and with the cyclosporin levels. So it makes it very unpredictable, and levels that goes up and down, like I told you before, can be toxic to the kidney, or it can cause low level predispose you to rejection. So we really advise using them as much as possible. We'll go to the next one. Healthy weight, very important, as you can imagine, to prevent heart disease, to help reduce your risk of diabetes, wound infections, and things like that. Most patients feel a lot better after transplant. They feel better, they eat better, and so weight gain is very common after transplant. So we want to keep an eye on that to make sure that doesn't get out of hand. The next one, so very quick summary. So kidney transplant will improve your survival and your quality of life. It definitely takes a village. So remember, your transplant team is big, and we're here to help you and support you every step of the way. Reach out. If you don't reach out, we don't know that you need help. And there are complications from the immunosuppression, but we can work with them. So it's definitely worth going through. And the long-term follow-up and medication adherence are the key to help you keep your kidney as long as possible. Okay, I think I will stop there and take questions. And again, apologies for the rough start. These are some useful sites where you can get a lot of good information.
Thank you for sharing those sites. Those do look like great ones that really offer a lot of information. And we completely understand the technology issues. They happen. Hannah actually said that it seems like there's a gremlin that's involved sometimes. And I think that's so true.
Yeah. So grateful for Hannah that was able to help out.
Yes, thank you, Hannah. We
My
really
pleasure.
appreciate you. So I see that Mike, it looks like you have your hand raised.
Yes, I am a heart transplantee as well, 6 years out. And regarding the COVID vaccine, are there any clinical studies that are available that will net better coverage than the current vaccines have for us? I took them. I've gotten the Moderna vaccine, and from what I've read, both kidney and heart transplantees, and maybe other transplantees, the vaccine does not supply the coverage that it does for healthy people, and you've kind of confirmed that today.
Yes, that's a great question. Yes, and that's why we are trying to do this study at Piedmont, because the study basically is about getting transplant recipients the vaccine. You know, everybody gets it on day 0 and then on week 4, but also is following those recipients to see if they develop antibodies against the COVID or not. And also we will monitor some markers of the immune system to see how the immune system is changing. So that study has not been done yet, so we don't have good scientific information like we're hoping to get if we can recruit enough people. We do have a little bit of information from Johns Hopkins that they actually reach out to transplant recipients that got the vaccine. And then if they wanted to participate, they were gonna monitor their antibody response through a kit that they sent home, so the blood could be collected at home. And what it came out was exactly what you're saying, that when they look at transplant recipients that got Moderna versus Pfizer, Moderna vaccine seemed to be a little bit better response, but compared to the general population, meaning people that are not on immunosuppression, the response was much lower, and maybe as low as 50%. And so we don't really know what that means. So could that mean that if you're vaccinated and you're a transplant recipient and you see COVID, you get it and you are more likely to get sick, but maybe you still get sick, but not sick enough that you need to go to the hospital? Because it did not translate, as far as we know, this is all new data, it did not translate into more hospitalizations or death. And that's really what we're trying to prevent with the COVID, right? We want to prevent you from getting so sick that you need to be on an intensive care unit, or that you need to be, you know, in the hospital, that you die, basically. And so that's why I think all the transplant societies are in favor of the vaccine, even though we don't have all the data yet. And so, because we think that it may reduce mortality just as well as it does in the general population.
A follow-up question. Is there any movement toward, say, a booster shot to raise that coverage over 50%?
Great question. Yes, probably. Again, we don't have the data. And that's one of the things that we're trying to answer with our study. Yes, and you know, there is questions if in general everybody, regardless if you're immunosuppressed or not, will need a booster like a year later, you know. And so maybe for transplant recipients is a couple of months later, you know, we don't know. So the answer is we don't know yet, but it seems likely.
Okay, thank you.
You're welcome.
Hannah, would you be able to go back to that slide on the study?
And if you go to, yeah, go ahead.
Oh, no, you please go ahead.
No, it was going to be the next one, I think, but that's okay. She'll find it.
Oh, okay.
Keep going. You're close, I think.
And he told me that there's a kind of life
So,
cycle.
do people? Oh, there it was.
Predictable
Do people need to be?
People are still
I'm
individual.
hearing background noise from somebody. If you could
group just yet.
mute yourself.
The second day, people start to group and
Hannah, if you can go two slides
form
ahead,
those little packs of people, and
in case anybody's interested.
Thanks so much. So kidney or liver recipients more than 6 months post-transplant. So is this study currently ongoing?
Yes, this study is currently ongoing at Piedmont. And so it's from Moderna and is in conjunction with the Medical European Society. And so we launched the study mid-April, and like, you know, all the research, there's always delays. So what we are running into is that most transplant recipients that we interact with have already been vaccinated, which is fantastic. We want that, you know, people to do. And so we're having a little bit of a slow recruitment because most people have received the vaccine already. But we're slowly making progress. So hopefully, you know, we can recruit at least 100 patients. Could have some data in a few months.
Thank you. We did have a question come in from someone saying, do the medications cause blindness?
So no, I wouldn't say that. I would say that long time exposure to prednisone can cause cataracts. And so cataracts, you know, can be severe and can be problematic, but There is surgery for that, where your lenses basically change. And so, no, it would not cause blindness. There are other risk factors for blindness, you know, like if you have a stroke, or if you have what we call an embolic event, so a blood clot in one of the eye, one of the retina arteries, and things like that. But a medication per se should not cause blindness.
Thank you. Somebody was wondering if there are studies involving non-mRNA vaccines.
I am not aware of that. You know, both Pfizer and Moderna are mRNA vaccines, and I'm not aware of any studies in transplant recipients with Johnson & Johnson.
All right, thank you. Somebody seems to have a question about vascular disease. Could you let us know what your question is about vascular disease? Oh, they asked, what can you do to make vascular disease better? Because their hips are bad now.
Yeah, so great question. So cholesterol control. So cholesterol, if your cholesterol is high, it's really hard to make it come down with diet alone. Diet helps, but most people will need medication. So cholesterol control is a big one. If you do smoke, stopping smoking, and that includes marijuana. So marijuana is also associated with cardiovascular disease. So stopping tobacco products, stopping marijuana. If you are able to exercise, you know, even a little bit of moving around could help. And then if you have diabetes, I would say diabetes control is very, very important. And one of the risk factors of vascular disease is also kidney disease. And, you know, that's why we want to keep your kidney healthy as long as we can. If you have advanced kidney disease, that's also a risk factor. And that we haven't been able to figure out how to make it better once your kidney disease is advanced.
All right. Well, somebody was asking, is it possible to get off of taking prednisone?
So that's a good question, and that's definitely a question that you want to talk to your transplant team, okay? Because there are risks and benefits of coming off prednisone. And so there was a good study about this many years ago, and where people came off prednisone, they were more likely to have rejection. And so rejection is something that we want to avoid. Rejection is something that we can, you know, usually treat, but not always. And yes, prednisone will give you, you know, maybe higher blood pressure, maybe, you know, increase your sugars, maybe bone disease. So there are side effects that in general, most transplant doctors feel like you can deal with the side effects better than deal with rejection. If you are thinking that prednisone is not good for you, definitely ask that question to your transplant doctor. It's a good question. So you don't want to stop it on your own. You want to have that discussion. And it's also going to depend on your immunologic risk. So who was your donor? How good a match were you? Were you sensitized? Like we said before, do you have any circulating antibodies against this kidney? So somebody may do really well off prednisone, and you say, well, my friend got off prednisone and they're doing great, but everybody has their own story. So you want to know, does that apply to you or not?
Absolutely. Thank you. Well, Dr. Rossi, we appreciate so much your time today, and you've shared so much important and great information for everyone. And we really give you a big applause and thank you so much.
Thank you, everybody. Thank you for your invitation and for all your questions.
Thank you. Well,